Okay, I think I have this up and running again. So I am going to start going through the female reproductive system. I'm going to do a little bit differently this time. I'm going to try and use some of the visual body 3D animation software, and I'm going to couple that with the female reproductive system. So we already went through this in lab or in lab setting. So what I want to do is to run the PowerPoint lecture alongside the anatomy that visual body has to present. So I posted the lecture and then I'll post this video so you guys, obviously, if you're listening to it. Oh, God. Oh, shoot. Okay, so we're going to do the female reproductive system in lecture. We've already gone through this in lab. I'm going to do it a little bit differently this time, see if it works. I'm going to use the visual body app as part of this to kind of augment, and then I'm going to go through the lecture slides alongside the visual body. So starting off with the female reproductive system, we will, let's see how well this works. In the wrong direction. Okay, so we've already gone through and we've talked about the gonads for the female reproductive system. Remember, the gonads for the female are the ovaries. I always like to compare it with the male. So for the male, we have the testes. Ovaries and testes do the same thing in general, and that's producing sex cells and sex hormones. So for the female, the ovaries are the site of sex cell formation. That's called oogenesis, or the meiotic division of these oocytes. Crazy that in females, this actually starts before a female is ever born. So usually begins about 12 weeks into gestation. So as the female transition from an embryo into a fetus, which actually happens at week 8, just shortly after that, she already begins production of her sex cells. Those cells will stop partway through meiosis, in fact, in prophase 1. And then once the female reaches puberty, we're going to find that a small group of those will be pushed into continued meiosis. And the very last stage of meiotic division will not even occur unless fertilization has happened. This is a view of the female reproductive system. So we're looking at it from that posterior view. We have the ovary in the center. Oh, sorry. This is really late. We have the uterus in the center, and we have the 2 ovaries on either side. The ovaries, I can tell we're looking from a posterior view because the ovaries are not visible from the anterior view very well. So we see the ovaries here, so I know I'm looking from a posterior view, kind of posterior, superior. I can see the fallopian tubes coming out and around, so these will move laterally around in that sort of pelvic floor. And I can see the nice thick connective tissue, we're going to name that later, called the broad ligament, kind of supports all of this tissue. This inset here is actually a photo of an ovary. You can see it has a really white coloration to it. So that's the tunica albuginea, has the same nomenclature as we find in the testis. So that's a really thick connective tissue covering to the ovary. And let's see, in our visual body, so I'm going to click over to our visual body. This is looking at the female. So what they've done is they kind of highlighted the structures in the bottom. So I'm just going to kind of review these. So we're going to start up here. This structure, of course, is the pubic symphysis. You can read that right here, pubic symphysis. Just behind the pubic symphysis, we have the female bladder and urethra. And then behind that, we have the uterus, right? So it's kind of posterior and superior. And from the uterus, we're going to have the cervix and the vagina. So this is the vagina. I can see kind of in this, I'll rotate over this way. So here's the uterus again. I have my fallopian tube coming off and then looping around. So it's actually a little bit more anterior to the ovary. So there's my fallopian tube. And then I have my ovary sitting right there. Okay, so I can kind of see that view. If I remove the sacrum here and kind of hide it, I can get a little bit better view of where my fallopian tube is coming out relative to my ovary. So if I'm standing back here and looking forward and down on my uterus, Notice the fallopian tube kind of sits anteriorly, and then I have my ovary sitting behind it, kind of in that little cup of the fallopian tube there. This is the fimbrious, and there's the ovary. All right, so I can kind of zoom in on that a little bit. See if I can move it around so you can see a little bit better there. Okay, so there's this fallopian tube here. See it coming off of the uterus and kind of wrapping around laterally. There's a little fimbria, and there's the ovary. All right, so that kind of gives us a nice three-dimensional view. I'm going to move this over just a little bit of the female reproductive system. Again, pubic symphysis, I have my bladder, my urethra, my uterus, the vagina, fallopian tube, ovary, and then back here, this of course would be the rectum and anus. So there's the rectum back here, and then that's a little piece of that sigmoid colon there. So rectum, and of course down here, that's the, oops, there's the anus. All right, so I'm gonna go back to my PowerPoint. So I'm looking at this again. This is that view if we were sitting way back here, kind of looking forward. So we have it view from this side, okay? All right. So now what we're going to do is talk about what happens in the ovary. In the ovary, we have what we call developing follicles. And in the female, you're born with about 2 million of these. And then between birth and sexual maturity, so as you start to go into puberty, you'll find that you go from about 2 million to maybe about 400,000. So we see a significant amount of atresia or loss of the initial follicles that we were born with. But when we reach puberty, we're going to take these little follicles. Follicles are going to be the oocyte and the surrounding follicular cells. We're going to stimulate them to develop. So when we're born, we have a whole bunch. We have about 2 million of what we call primordial follicles. So this is going to be an oocyte, that's the sex cell, with the supportive nutritive cells around them. Now these guys are quiescent at this point, which is why they're squamous. You can kind of see that flat nuclei. But if they're stimulated by follicle stimulating hormone, they'll start to develop, and they'll go from a quiet sort of squamous shape into an active cuboidal shape. So this is a developing follicle right here. I can tell that because I have my follicular cells, which are now actively producing hormones in a cuboidal shape, and there are actually more than one layer of them. In a female normal ovarian cycle, which lasts for 28 days, we're going to find that on average, follicular development will take place between day 1, which is day of menstruation, to day 14. So we'll have this development of that follicle. We're going to see that these follicular cells are actually going to mitotically divide, and there'll be many, 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 many more of them as we approach day 10 and day 12. And their job is to make a ton of estrogen in that what we call follicular phase, which is the first half of a female cycle. And then after ovulation, these follicular cells actually remain behind and produce and become a hormone producing factory. And at that point, we'll call it the corpus luteum. So we'll talk about that in just a minute. So this is some thecal cells. These are connective tissue cells that are kind of surrounding the follicles as they're developing. And then the granulosa cells, these are going to be the cells that are collectively referred to as the follicular cells, the actively producing hormone cells. All right, next we're going to look at follicular development. Again, this is going to start when a female reaches puberty. So she's going to be born with what we call primordial follicles in essentially an egg nest. So they actually call it an egg nest inside the ovary. And that'll be in this cortical layer of the ovary. So the primordial cells, when a female reaches puberty, will start to awaken from that arrested period of development by follicle stimulating hormone. So this is a hormone released from both males and females, but it gets its name from what it does in the female. But the reality is it does essentially the same thing in both genders. So in females, it will stimulate the sex cell development, and it does the same thing in males. So follicle stimulating hormone in females drives follicular development, and follicle stimulating hormone in male drives spermatogenesis, okay, or this spermatid development. So It's released from the pituitary gland, and then it travels systemically to the ovaries, where it starts to encourage these follicular cells and the oocyte they surround into development. And so we go to this process of follicular development, which is about the first half of a female 28-day cycle. And so we're looking at about 14 days until ovulation. So here we see sort of this developmental stage. So day one, we see these primordial follicles becoming a primary follicle. So this happens usually for about 10 to 12 of the follicles that reside within both ovaries. So collectively, you'll have about 10 to 12. So maybe 5 in one ovary and 6 in another. We can see here follicular development, and what you can see is that the number of follicular cells is increasing. As their number increases, they're going to make lots and lots of estrogen, and that concentration of systemic estrogen will grow throughout that first 14 days of the cycle. In fact, it's the increasing level of estrogen that's going to stimulate the pituitary gland to release the ovulatory hormone called luteinizing hormone. So the follicle itself is really signaling to the pituitary gland its readiness to ovulate by being large enough to make a high concentration of estrogen. So this is right around day 12, day 13. This is right before it's about to ovulate. You'll notice that not only do we have lots of follicular cells, we have this large central antrum that'll be filled with follicular fluid, which is also made by these follicular cells. So that'll start to accumulate. That's going to create an internal pressure. In fact, we're going to call this mature follicle or Graafian follicle a functional cyst, because it's going to be filled with fluid, and that fluid will eventually create so much internal pressure it'll cause a rupture of that functional cyst. All right, so next, this is looking at sort of that progression of development between the female. So here we're looking at the oogenesis. So if you were watching the division of chromosomes, and here we're just looking at the overall development of the whole follicle. So they're kind of showing you over here, this little pink guy, that would of course be the oocytes. You kind of see what's happening chromosomally versus what's happening in the follicle. So again, at birth, we have about 2 million of these partially divided oocytes. They're going to sit at prophase 1 of meiosis, which is the very beginning of meiotic division. And the most interesting thing about females versus males is females are born with a set number of oocytes that we essentially just simply lose throughout our reproductive life. Males have that resident level or ring of spermatogonium that will always go through an initial mitotic division, so divide to create another spermatogonium, and then they'll go through meiosis. So they always have this resident number of sperm cells that are produced new every day. So you get this new group of cells, which is why males can be sexually active and be able to have children way into their 70s, which is crazy. For females, eggs have been around longer than technically we've been, well, I wouldn't say alive. I guess it depends on how you define it, but we have egg cells that have been around longer than our age is. So if you're 33 years old, your egg cells have been around for almost 8 months longer than you've been on, walking around. Well, been around. You weren't walking when you were born. Anyway, so for females, we have a set number of oocytes that we're going to lose throughout our lifetime, and they've been around since we were born. And so they're just as old as we are. Where males make new cells every day, they're only going to be usually, the maturation process takes about 9 weeks. They'll only be about 9 weeks old. The problem for females, though, is that oftentimes the chromosomes, because they've been sitting in that sort of arrested or frozen stage of meiosis, the chromosomes actually can stick together. And that's actually what causes Down syndrome or trisomy 21, where the chromosomes don't actually separate correctly, and you get 3 chromosomes in one cell and 1 in another. Anyway, so that's kind of a side note, but this is looking at the follicular development. So you can see here primordial follicles, which we're born with. And then here it says before birth, childhood ovaries are inactive. And then from puberty to menopause, this is where we're going to start to see this development. So we're going to see these primordial follicles develop into primary follicles and then growing follicles and eventually mature follicles that can ovulate. What's nice in this diagram is they're showing us that the follicular cells, once ovulation has occurred, are still active, and they're going to be a very large hormone factory called the corpus luteum. So remember, corpus means body, luteum means yellow, and it's yellow because the cholesterol is going to be the precursor for estrogen and progesterone. All right, and then just a little inset looking at one of those little primordial follicles. Okay, so at puberty, we have about 400,000 primordial follicles that will be used every month. We're going to use a small clutch of them. Like I mentioned, usually on average, you have between 10 and 12 oocytes that will, or follicles within the oocytes. So the follicles with oocytes inside will then be pushed into meiosis, but only one of that clutch will actually or usually only one of that clutch will actually reach maturity and get to ovulate. This whole process is stimulated by follicle-stimulating hormone. It starts usually between 11 and 13 years of age for most girls, and usually ends between 45 and 55 years of age for most women. So we have a reproductive life that starts in our early teens and ends somewhere in our late 40s, early 50s. In fact, if you get pregnant in your early 40s, you're really lucky. All right, so next is looking at the follicular developmental stages. So this is looking at a drawing of an ovary, and they're showing you out here, this is a thin group of cuboidal cells at the surface. And then we have, these are the connective tissue cells. So this is the tunica albuginea. And then this is what we call the cortex. And the cortex has all these little primordial follicles kind of sitting, waiting with their squamous follicular cells. This is looking at day 3. So day 1 is your first day of menstruation. Most women menstruate for 5 to 7 days. And so when I was younger and I was menstruating, I kind of thought my reproductive system was on hold. But the reality is, as soon as you start menstruating, you're already beginning your next cycle, which is why if you get pregnant, one of the questions that always gets asked was, when is the first day of your last period? And I always wondered, well, why they want to know that? And the reason they want to know that is because that's the day that your follicles began to develop for that particular cycle. So if you got pregnant in that cycle, you know exactly when your follicle, your baby, essentially, started to develop. So you have this 2 weeks of development before ovulation occurs that you're actually going to count as part of your baby's development. So day 3, if you're using an ultrasound, you can actually see all those little follicles developing in a particular ovary. So this is an ultrasound of an ovary, and you can see these little dark spots. Those are all follicles. So if we were to count them, you have 1, 2, 3, 4, 5, 6 follicles in this particular ovary, and you might have another 5 or 6 on the other ovary, which gives you about 10 to 12. So this is pretty normal. And I don't know about you, but I was shocked to know that, so early in my cycle, I'd be able to tell exactly how many follicles were developing. All right, once they move from the primordial follicle, they go into a primary follicle. And again, all you're looking for is cells that move from that squamous to a choroidal phase. And so I know at this point, the follicles are developing. This is what I might see on an ultrasound. I'm going to see this as a dark spot. And then once they move from a primary follicle, they move to a secondary follicle. And then I'm going to start to see this antrum start building. I'm going to see many more layers of the granulosa cells or follicular cells around. These guys are going to be making more and more higher and higher concentrations of estrogen as they're more and more active. You definitely can see that there's a large clutch of oocytes that are still in this sort of waiting phase out here. They're still going to be waiting for hormones to, follicle stimulating hormone to initiate them. But this is definitely a growing follicle. And then eventually we get to the point where you have what's called a tertiary follicle. This one's fairly easy to identify because The follicular cells basically kind of make a projection called the cumulus oophrys, and it allows for when the follicle ruptures, the oocyte to be broken off with a surrounding, what they call corona radiata, that will surround the little oocyte on its travel into the female accessory structures or duct system. So here we see an oocyte that's almost ready. You can see a large number of follicular cells. I can see the oocyte. This one still needs a lot of development in order to get to this phase. But here we see a large antrum with a lot of follicular fluid. This usually takes about 10 to 14 days. On average, usually at day 12 is when they are signaling to the pituitary gland that they're ready. And then usually within a day or two, depending, they will then ovulate. So if we're looking, keep going the wrong way. There we go. If we're looking at ovulation, timing-wise, you can see ovulation for most women occurs at day 14. Usually between day 10 and day 12 is where you see this really nice spike in estrogen levels. So estrogen, this drawing is this pink number or pink line. And this then will stimulate a surge in what we call luteinizing hormone. Luteinizing hormone is what is going to cause the corpus luteum, that yellow body, to develop, and that results from ovulation. So luteinizing hormone is our ovulating hormone. It's secreted in response to high levels of estrogen, and it causes a thinning of the ovary surface and allows for the internal pressure of that follicular fluid to literally cause a rupturing event to occur. And here you can see one of those follicular cysts rupturing. This is follicular fluid, and inside would be the egg. Follicular fluid is in fact super chemotaxic, and it will even draw a fallopian tube from the opposite side of the body across the perineal floor. You can have an individual who's had an ovary removed. Maybe it had a polycystic ovarian disease of one ovary. If you take that ovary out, the fallopian tube that no longer has an ovary associated will literally migrate across the pelvic floor to the other ovary because of the chemotaxics of the follicular fluid. All right, so that's what we're looking at here. This is this ovulation event that is stimulated by the luteinizing hormone. We can see that the follicular cells that are left behind in the ovary then become what we call the corpus luteum. So this is the luteal phase, and that's from day 14 to day 28, versus the follicular phase, which is the first half of the cycle. All right, so keep going the wrong way. All right, so again, we're going to see that the follicular cells are really charged with producing hormones. This is actually a really cool photo of an ovary, and you can see this really large yellow body. That's the corpus luteum. So this is an ovary that is in an active luteal phase. This is one of the follicles that didn't quite make it. So this would have been one of those 10 to 12. You can see there's a lot of fluid there. So it was large, but wasn't large enough to ovulate. And then we can see all these little white marks. Those are previous corpus luteal scars. Those are called corpus albicans because they're white. So, and you can see this is the cortex region. So this is where all of those wonderful primordial follicles are going to be residing. So blood comes in, carrying with it follicle stimulating hormone. It stimulates a clutch of follicles to develop. And what we're looking at is, at this point, one mature corpus luteum. So this person is somewhere here at the end of their cycle. They're pumping out large amounts of progesterone and estrogen, and hopefully for them, those hormones are going to be supporting the growth of the uterine lining in anticipation of a fertilized egg. So again, after ovulation, the follicular cells become a structure called the corpus luteum. That's what we see here. And they're going to make large amounts of estrogen, progesterone. And the reason it's yellow is because these are produced from cholesterol. Cholesterol is a precursor, and cholesterol kind of has that yellow coloring to it. All right, so this is a quick little video on ovulation.
Ovulation is a part of the menstrual cycle when the ovary releases a white egg, or ovum. Inside the ovary are hundreds of thousands of follicles. Each follicle is a hollow ball of cells with an immature egg in the center. The typical 28-day menstrual cycle begins on the first day of menstrual bleeding. During the first 7 days of the cycle, a few follicles begin to grow at the same time. These maturing follicles secrete estrogen hormone into the bloodstream to prepare the lining of the uterus for pregnancy. Around day 7, all of the follicles stop growing and begin to degenerate, except for one. This dominant follicle continues to grow and nourishes the developing egg inside it. Around day 12, the follicle secretes a large amount of estrogen into the bloodstream. When the estrogen reaches the hypothalamus and the pituitary gland in the brain, the anterior or front part of the pituitary gland releases a huge surge of luteinizing hormone into the bloodstream. Around day 14, luteinizing hormone causes the follicle to undergo a sudden growth spurt. Right before ovulation, the egg detaches from the inside of the follicle. The bulging follicle releases chemicals, causing one of the two fallopian tubes to move in closer and surround the follicle. The follicle swells until it bursts open, ejecting the egg and fluid from the follicle into the abdominal cavity. In response, the fimbriae, tiny projections at the end of the fallopian tube, sweep across the ovulation site and pick up the egg. Microscopic cilia on the fimbriae surface transport the egg to the entrance of the fallopian tube. Inside the walls of the fallopian tube, muscular contractions gently push the egg towards the uterus. After ovulation, the egg lives for 12 to 24 hours, so it must be fertilized by a sperm from the male during this time for a woman to become pregnant. If it's not fertilized, the egg dissolves away and is shed along with the uterine lining during menstruation.
Okay. Let's see. All right. So then this is looking at the ovary location. Again, it's nice to have this 3D, so I'll show you this in just a second. But again, when we look at where the ovaries are sitting, the ovaries kind of sit right at the pelvic inlet, just on either side of the iliac bone. So remember, this iliac bone is going to have this nice internal concavity called the iliac fossa. And where they narrow as they approach the pelvic inlet, which is this right here, they're going to sit right on that edge there. So right at the level of the pelvic inlet, just lateral to the uterus and posterior to the fallopian tube or uterine tube. So this photo is an endoscopic photo looking inside a female pelvis. And this up here, this would be anterior, and this would be posterior, and I can tell that one because there's my rectum. Here's the uterus right in the center, and I have my fallopian tubes on either side, and my ovaries are behind them. So I can tell this is posterior, some adipose tissue around the small intestine. And then up here, the bladder would be underneath this perineal floor here. All right, and then if I look at my visual body, let me see if I can do another view. So this is looking kind of down into the pelvis, and you can see they would be sitting right on either side of that pelvic inlet of the female. So if I kind of move it this way, you can kind of see they're right along the edge of that pelvic inlet. Okay, so this would be the pelvic inlet. Of course, down here, this would be the pelvic outlet. Okay, so next. There we go. Size-wise, and I'm not a stickler on sizes, but just kind of get an idea of size. So about 4 centimeters by 2 centimeters by 1 centimeter. So you're kind of looking like a flattened fig, you know, kind of the size of a flattened fig. And stabilized by some really great ligaments. So if we're looking at this view again, this is the bladder, so this is anterior. This is posterior, so there's the rectum. I'm right at the pelvic inlet, and so I'm going to have my ovaries sitting on either side. I'm going to have my really nice tethers tying the ovary to the sides of the uterus. These are going to be called ovarian ligaments. And then I'm going to have my suspensory ligaments, which I can see right here. And these are just simply blood vessels coming down that dorsal body wall. And they're going to be surrounded with connective tissue that allows them to route out to the ovaries. And so that provides some support. And we call that the suspensory ligament. So the ovaries are kind of suspended between the body wall and the uterus by the ovarian ligament and the suspensory ligament. Okay. All right, and this is going to contain, like it says right here, the ovarian vasculature. So this would be what we call the gonadal or the ovarian artery and vein on each side. All right, so over here, if I'm looking, I can see right down there, if I turn it this way, this would be my ovarian ligament. You can see that up there on either side. There's my ovarian ligament. And then this one actually doesn't show the suspensory, so I'd have to probably pull up vasculature on this, but the suspensory ligament would be coming down right here and suspending the ovary to the lateral body wall. All right, so next we're going to look at, there it is, the fallopian tubes. The fallopian tubes, like in the little video there, they're pretty amazing. These are little muscular tubes. They're going to be wide at their entrance so they can surround the ovary. There's going to be these little finger-like kind of fringe extensions called fimbriae, and they're going to actually move and create suction. So it's smooth muscle. They're going to be lined with cilia, and that's also going to help move the little oocytes in. Now, oocytes, unlike sperm, don't swim on their own, so they have to be guided and kind of pushed down the fallopian tube. Fallopian tube length is about 4 to 5 inches long and takes usually about 3 to 4 days to travel that distance. So if we were to ovulate an oocyte here, it would travel into the fallopian tube. So we have the little finger-like projections. Those are called fimbriae. And then I move into what we call the infundibulum. That's kind of like a catcher's mitt here. So it's going to be like where you would catch a ball. So you kind of imagine you're going to ovulate right into that infundibulum. And then we're going to turn. And this turn right here is called the ampulla. It usually takes a day to get to the ampulla. And since oocytes are only going to be around, and I shouldn't say around, but viable or capable to be fertilized for 12 to 24 hours, we say the site of fertilization is in fact going to have to be this ampulla. And it has to take place in this very first day of travel. So traveling will be done by peristalsis of the smooth muscle and the guiding of the cilia. So very similar to what we see in the respiratory tract. The cilia is very, very similar. All right, so timing-wise, it takes about 3 to 4 days to travel this 4 or 5 inches. When I was first learning this, I wondered why we needed a fallopian tube. I think I mentioned in the lab lecture, I always wondered why you didn't just ovulate directly into the uterus. And there are a number of reasons for that. One is that if you remember, for the follicular phase, the first half of that phase, remember 5 to 7 days, you're going to be menstruating, which means you're getting rid of the lining to the uterus. That's going to be able to support the next pregnancy if you have one. So you really only had about 7 days to develop a new uterine lining, and that's really not quite enough time for the lining to be able to support a new pregnancy. And so we needed to have a few more days. In fact, 4 to 5 days would give it, more like 10, 12, 14 days before the little oocyte comes in and implants. Most implantation events occur between day 7 and day 10. So we're going to need that little bit of time to make sure that uterine lining is ready for implantation. So that's one of the reasons we have to have this fallopian tube. It just gives time for that uterine lining to develop. And then the other is, remember, if you've had intercourse, you've just deposited about 3 million sperm into your vaginal tract. And we don't want all of those sperm to come and bombard the egg. We want to make sure that we get the very best of that 300 million. And so we're going to basically make them run a gauntlet. And so they have to swim all the way through the female reproductive tract. And so really only the strongest sperm are going to make it to that egg. All right, so Next, we'll look at a video on fallopian tube.
Ovulation is the release of an egg from one of the ovaries. It often happens about midway through the menstrual cycle, although the exact timing may vary. In preparation for ovulation, the lining of the uterus or endometrium thickens. The pituitary gland in the brain stimulates one of the ovaries to release an egg. The wall of the ovarian follicle ruptures at the surface of the ovary. The egg is released. Finger-like structures called fimbriae sweep the egg into the neighboring fallopian tube. The egg travels through the fallopian tube, propelled in part by contractions in the fallopian tube walls. Here in the fallopian tube, the egg may be fertilized by a sperm. If the egg is fertilized, the egg and sperm unite to form a one-celled entity called a zygote. As the zygote travels down the fallopian tube toward the uterus, it begins dividing rapidly to form a cluster of cells resembling a tiny raspberry. When the zygote reaches the uterus, it implants in the lining of the uterus, and pregnancy begins. If the egg isn't fertilized, it's simply reabsorbed by the body, perhaps before it even reaches the uterus. About 2 weeks later, the lining of the uterus sheds through the vagina. This is known as menstruation.
All right, so next we're going to look at is, there you go, the regions of the fallopian tube, and I already went through this, but just as a review, this is again looking at the uterus from that posterior view, and again the reason I can tell is because I can clearly see my ovaries, and they're going to be posterior to the fallopian tube or uterine tube. Again, we're going to tether those ovaries utilizing the using the ovarian ligament. And here's a little piece of that suspensor ligament up there. So we look at the fallopian tube. Again, these guys are about 4 to 5 inches long. They're going to actually be really narrow. So the inside lumen space is about the size of a pinprick. So it's very tiny on the inside. But at the level of the ovary, we're going to have this sort of widened area. Again, that's called the infundibulum. And coming off the infundibulum are these little finger-like projections called fimbriae. So this is a photo. You can see the fimbriae out here. Now these are muscles. And so they're going to start to beat and create an internal pressure that's going to really create suction. They're also going to sweep over the surface of the ovary. So unlike males where the reproductive tract is continuous, in females, we actually ovulate technically into our abdominal cavity or pelvic cavity. And the fallopian tube's job is to catch them. So we're going to have a lot of connective tissue here keeping these two structures together. But the fimbriae are going to start to make sure that they start moving and creating that internal pressure that sucks the ovulated oocyte in. Remember, the follicular fluid is very chemotoxic, and we'll make sure that this connection is quite substantial. As we enter into the fallopian tube, again, we have the fimbriae and then the infundibulum. We're going to hit this hook here, and that's going to be the ampulla. So there you go, the ampulla. This is the most common site of fertilization because it takes about a day to get there. And then we're going to hit the isthmus, which is where it narrows. And this is usually what we talk about. That would take about 4 or 5 days. And then usually it takes another 3 to 4 days to actually get inside the uterus. We don't have quite the same motion occurring anymore. There's no cilia at this point. And so it takes about 3 or 4 days to finally implant. And again, implantation usually takes place between day 7 and day 10 in the uterine lining. All right, so we have this section here, the fallopian tube actually going through the uterine muscle to enter the uterine cavity. And so they call this portion the intramural portion. All right, so this is just a nice drawing. This one's out of your textbook and kind of showing you the progression that takes place if fertilization happens. So here's ovulation. Again, remember that's day 14. So this little egg here has actually had about 2 weeks to develop at this point. If it's fertilized, which happens here that very first day, 12 to 24 hours after ovulation, they'll finish the last mitotic division, toss out the last 23 chromosomes, and be able to unite with the sperm's chromosomes. And then what we're going to see is a very rapidly dividing little ball of cells. Usually about day 3, you have about 16 to 30 or so cells. Day 4, out here, we see this really nice cluster. Usually this about 30, 40 cells. And then eventually we're going to see what's called a blastocyst. This is where we see our first germ layers developing. So remember our ectoderm, endoderm, and mesoderm. That's going to be in the blastocyst. And again, usually implantation is sometime between day 7 and day 10. All right, so if we don't implant uterus, now remember the ovary and the fallopian tube are not technically connected, so you can have an abdominal pregnancy, but it's very unlikely because the serous membranes that line the cavity don't really house enough nutrients to support a developing embryo. But the most common site for what we call ectopic pregnancies, and this means a pregnancy that's occurring outside of the uterus, is going to be one that occurs in the fallopian tube. And that's because it's fairly easy for sperm to swim up, because they're self-propelling, up a fallopian tube that may be somewhat blocked or maybe kinked a little bit. But if the oocyte is fertilized and you have to rely on the cilia to move and the peristalsis to help guide, sometimes a minor block can be quite an obstruction for a fertilized egg, and they may get lodged within the fallopian tube and then start to develop there. But there's really not enough nutrients, and as the little embryos start to develop and increase in size, eventually what happens is those little fallopian tubes can't handle the size, and they basically rupture and cause a lot of internal bleeding. So it's really important to make sure if you're pregnant that you go and do a sonogram to make sure that the pregnancy is actually occurring in the uterus and not ectopically in the fallopian tube. So this is a photo looking at someone who is experiencing ectopic pregnancy. So we can see here's the fallopian tube, and you see how large it is here. There's an embryo developing inside that fallopian tube. So surgically, they would have to go in and remove that developing embryo so it wouldn't cause rupture and bleeding to the mother, and potentially cause essentially that side, if it ruptures, the woman to not be able to have children off that fallopian tube anymore. It's about a 2%, a little bit less than a 2% chance of a known pregnancy has this problem. A lot of times you have ectopic pregnancies that just don't progress. And so many women will say, oh, I'm pregnant. And then they'll say, like, a couple of weeks later, oh, I'm not testing pregnant anymore. And maybe they might have had an ectopic pregnancy that just didn't progress. All right, so this is a little clip on ectopic pregnancies.
Normally, a fertilized egg implants in the uterus. But if the fertilized egg implants somewhere other than the uterus, the pregnancy is said to be ectopic, which means located in an abnormal position. When an ectopic pregnancy occurs, the fertilized egg usually implants in one of the fallopian tubes. Because the fallopian tube is narrow and its walls are thin, the pregnancy only has to be about the size of a jelly bean before the fallopian tube bursts, causing major bleeding. Occasionally, the fertilized egg may implant on an ovary, in the abdominal cavity, or in the cervix. Ectopic pregnancies are rare. They occur in about 1 out of every 60 pregnancies. There are certain risk factors that make an ectopic pregnancy more likely. These risks include a history of pelvic inflammatory disease, or PID, sexually transmitted diseases such as chlamydia or gonorrhea, a previous ectopic pregnancy, or a previous tubal surgery for infertility. Treatment of an ectopic pregnancy, either medically or surgically, is necessary to prevent serious, even life-threatening complications.
Okay, so, I know. Up here. There we go. Oh, I went the wrong way. Did I? Oh my gosh. All right, so I think, these are just pictures. So an ectopic or tubal pregnancy, again, these are just photos of pregnancy. So here you can see this is called an ambulatory pregnancy. So this is where the pregnancy, you can see there the little embryo developing in the ampulla. I can see here the surgical instrument kind of holding the ovary to one side. And then this is going to be a pregnancy that occurred further inside of the fallopian tube. So this would be what they're referring to as a tubal pregnancy. So this might be further down toward the isthmus. The increases in ectopic pregnancies occur when you have things occurring like if you have someone who has a previous STD, you may have tubal scarring. If you have had severe endometriosis, sometimes you can have endometrial tissue, that's the lining of the uterus that refluxes into the fallopian tube and doesn't get all the way out, and so it can cause blockage. If you have endometriosis that produces adhesions on the outside surface of the fallopian tube, that can cause tubal pregnancies. If you've had internal trauma, so if you've had a ruptured appendix, that can cause scarring and adhesions and kind of twist the tube. And then smoking, go figure. Smoking actually affects the cilia, so they don't manage to migrate the oocyte down the fallopian tube very well. So if it's a zygote, that then causes a problem. So lots of reasons that someone might be experiencing tubal pregnancies. The most common would be an STD. All right, so next we'll look at the uterus. So the uterus is in fact the site of embryonic and fetal development. It sits essentially in the pelvic floor, so it kind of lays down across those bottom pelvic floor muscles. It's going to sit, again, like we mentioned, in front of the rectum, but it's going to sit kind of behind and above the bladder. Remember that's kind of, it sits between the urinary system and the digestive system, but remember it's going to be kind of tilted forward in what we call an antegrade position. You can see that here, so it's kind of tipped forward over the bladder. And in someone that's not pregnant, it's about a little bit more than 1/10 of a pound. But if it's pregnant, you're going to see that the smooth muscle can actually increase, and we actually get a really thick inside lining. And so a pregnant uterus can weigh up to 2 pounds. So size-wise, 4 inches usually at the length of a non-pregnant uterus, and then can be almost a foot or more if it's pregnant. It's going to be housing a baby. All right, so this is looking at the uterus, and then again we can look at this view. I kind of twist it around, and I can see here, here's my bladder, and there's the uterus kind of tipped forward. Kind of see, maybe if I hide my pelvis here, I can see a little bit better view. Get rid of all my pelvic structures. Yeah. So I can see a little bit better there in my uterus. So see how it's tipping forward. This is what we call antegrade, or a normally facing uterus. And again, here's my fallopian tube kind of coming off and wrapping posteriorly and around, and then tucked into the arm there. That's my ovary. And again, that's my fallopian tube. All right. So, this is just looking at pictures of a pregnant uterus. So this is about 5 weeks into development, and you can see this inside lining of the uterus where the embryo has implanted is going to start to enlarge. And we see that the embryo tissue is going to invaginate and cause the growth of a reproductive organ that we only see when a woman is pregnant. That's going to be the placenta. And the placenta is going to be a organ that will really be a combination between the mother and the child. And the placenta will be a site of many things happening. The most important would be exchange between the mother and the baby. So the mother will supply the baby with nutrients and respiratory gases, but will also be a way for the baby to get rid of waste products. So the very same waste products we find in urine from the mother might actually be also a mix of, and I shouldn't say might, will be a mix of baby waste products as well. So this is looking at a woman that's 39 to 40 weeks pregnant. So this would be, most pregnancies go between 38 and 40 weeks. And so here is a baby. You can see the very large placenta. The abdomen, of course, is distended. Remember, when we talked about the abdominal wall, you're going to see your abdominal muscles basically being shifted laterally, so that linea alba is going to be stretched way out. And then you can see just the distortion and movement of abdominal organs. You can see up here all the intestines are squished up underneath the rib cage. Okay, so the uterus has several regions to it. So we're going to start off with the fundus. We actually use the same nomenclature that we used for the stomach. So the fundus is this sort of rounded portion to the uterus that sits above where the fallopian tubes are. So this is what's referred to as a photo. That would be the fundus. If we look at this image here, the fundus is this sort of rounded superior edge above where the fallopian tubes come in. And if I look here, this would be the fundus. You can see the fallopian tubes right here. So they're highlighting that section above where the fallopian tube comes in. All right, so the body is going to be that sort of medial tapering area. This is the most common site for implantation. In fact, it's the best place for implantation to occur because it's further away from the cervix. So you kind of have a nice high implantation. There's a lot of nutrient layers there for the endometrium for implantation to occur. It allows for a really good expansion of the uterus. This is what we call a hysterosalpingogram. So what they do is they actually inject through the vagina a radiopaque dye. So it's going to go into the cervix. So the cervix would be right here and into the uterine cavity. So this is really just looking at the space inside the uterus. So we're really just looking at this space right here. And these really thin lines, those are the fallopian tubes, at least the inside of them. So you can see how super teeny tiny these guys are. They're very thin. And you can see as it expands out here, this would be the infundibulum on either side. All right. And then the isthmus is where we're going to narrow as we approach the pelvic outlet. And this is where the cervix will be sort of projecting about half an inch down into the vagina. So when we look at the isthmus, we're going to see it narrowing, right? And it narrows into this really thick sort of muscular ring referred to as the cervix. So it's just this inferior portion projecting about half an inch down into the vagina. So if we're looking from the baby perspective as we're going out of the body, they refer to this inside ring of the cervix as the internal os, and this outside ring here as the external os. So os being this opening through the cervix. Okay. All right. So when we look at the uterine wall itself, there's 3 layers to it. So this inside layer is the layer that's constantly being built up and then lost, and then built up and then lost. We want to make sure that every pregnancy gets the best sort of layer, newest layer of blood vessels and glandular tissue for implantation. So we're constantly remaking that layer. So that's called the endometrium, endo meaning inside, metria referring to uterus. We have this very thick wall. In fact, 90% of the wall of a non-pregnant uterus is going to be myometrium. So that's the smooth muscle. And then the very outside layer is really just the parietal peritoneum that goes over the uterus. So at that point, we call it the visceral peritoneum or the perimetrium. So peri meaning around. All right, so in this drawing here, they're showing you the uterus cut open, and they're highlighting in green the myometrium. In blue here, that would be the perimetrium or the visceral peritoneum. And then the inside layer here, that would be the endometrium. Okay? The myometrium has 3 layers of smooth muscle, so very similar to the stomach and the bladder. We're going to utilize 3 different layers to make sure we get some really effective pushing. So when a woman is ready to give birth, more effectively can push the baby out through the cervix and into the vaginal canal. All right, so The endometrium is the inside layer, and what I did here is I took pictures of the histological images. So this would be an endometrium that's just finished shedding and is in the beginning part of rebuilding. So this is kind of looking at a lateral view, and you can see that these are glands, and we're just getting more and more glandular tissues. This is going to be mucus secreting glands that will afford some nutrition for a implanting embryo. And then these are cross sections through those glandular cells. You can see they're really thick, productive glandular cells during this proliferative phase. So this is a drawing of what would happen in the uterus, but trying to show you the progression of endometrium. Remember, day 1 is the loss of that endometrium. So this is starting day 1 during menses. So this takes about 5 to 7 days. As soon as you lose the lining, you're going to start to rebuild it. So remember, halfway through the cycle is when we're going to have ovulation, but we're not quite ready for implantation. Remember, that's going to take at least another 7 days, which is going to put us right up here where the lining's the thickest. Yay! So this would provide a really nice nutritive layer for implantation to occur. But if implantation doesn't occur, we're going to see that uterine lining start to shed again, and this is where we're going to see that menstruation. So again, this would be that day 1 as we shed that lining. The uterine lining is going to be stimulated by initially estrogen and then followed by estrogen and progesterone. Again, if there's no pregnancy, these hormones will start to reduce in concentration in the blood, and that will then cause the lining of the uterus to shed. All right, so regression of the corpus luteum is what's going to cause this regression in concentration of estrogen and progesterone. So in the absence of these hormones, the endometrium gets shed, and this is that process of menstruation. So this just looking at the inside line, that endometrium is going to get lost, and we'll start to have menstrual bleeding. All right, but if an embryo does get fertilized and does implant, then the endometrium is really what forms that placenta, which is that unique maternal fetal union of blood vessels. So the blood vessels actually don't connect, but they're going to run really close to one another and allow for exchange to take place between the mother and the developing baby. All right, I thought I'd just throw in a little bit on endometriosis. And I don't know what happened to my meeting. Well, maybe I'll lose my Zoom for now. We'll see if this works. I don't know if it'll keep going. But talk a little bit about endometriosis. So in endometriosis, what's going to happen is the endometrial lining, instead of getting pushed out, actually can reflux through the fallopian tube and out, and then onto either the ovary, the outside of the fallopian tube, the outside of the uterus, or the intestines, or anything that's down by the reproductive organs. So this is actually looking at the floor of the abdominal cavity. So here's the uterus. This would be the peritoneal floor. So this is that serous membrane, the parietal peritoneum. And here you can see it says endometriosis. And these are the little sort of endometriotic tissue that's kind of sitting on the parietal peritoneum that's causing swelling here. And oftentimes, if you have endometrial tissue that's sitting in your abdominal cavity, it will respond to the same hormones that are stimulating the inside lining, and so they will then start to shed. And that's what causes a lot of cramping and pain, and can cause the fallopian tube to get twisted or scarred. All right, so this is a quick little video on endometriosis.
Endometriosis is a condition where tissue, similar to the lining in your uterus, grows in other areas of your body. If you are a woman, your reproductive system includes the vagina, uterus, fallopian tubes, and ovaries. During a normal menstrual cycle, your ovaries make chemicals called hormones, which signal the lining of your uterus to thicken. The lining, called the endometrium, builds up to prepare to receive a fertilized egg. If the egg isn't fertilized, the uterus sheds the lining through your vagina. This monthly bleeding is called your menstrual period. If you have endometriosis, the lining-type tissue grows outside your uterus for reasons that aren't clear. The misplaced tissue responds to the hormones just like it would if it were inside your uterus. The tissue continues to thicken, then sheds and bleeds with every menstrual cycle. However, the blood and tissue that are shed outside the uterus have no way to leave your body. The trapped endometrial flow can irritate the surrounding area, causing inflammation and pain. Bands of scar tissue, called adhesions, may form, sticking one organ to another or causing your fallopian tubes to close. This can affect your fertility, which is the ability to become pregnant. Endometriosis can form endometriomas, also known as chocolate cysts. These cysts are fluid-filled sacs on your ovaries that can affect fertility. Endometriosis may also result in abnormal bleeding. The most common sites for endometriosis are the ovaries, fallopian tubes, the outside of your uterus, the supporting structures around your uterus, and the lining of your pelvis called the peritoneum. Other sites include your bladder, rectum, and intestines. If you have endometriosis, you may have one or more of these symptoms: chronic, usually worsening central pelvic pain, pain before or during your period, pain during sex felt deep within your pelvis, painful urination during your period, painful bowel movements during your period, abnormal bleeding, diarrhea, constipation, or nausea, and difficulty getting pregnant called infertility. Your doctor may recommend treatment options from the following categories: pain management medications, such as aspirin, acetaminophen, or non-steroidal anti-inflammatory drugs, also known as NSAIDs, provide relief from pain. Hormone therapy, such as birth control pills, can prevent monthly endometrial buildup and bleeding. You may need a surgical procedure to treat the tissue causing pain or bleeding. Examples of such procedures include removal or destruction of endometrial tissue, removal of adhesions and scar tissue, removal or drainage of cysts, removal or destruction of nerve fibers that transmit pain, removal of your uterus, called a hysterectomy, or removal of your ovaries, called an oophorectomy.
Okay, so the incidence of endometriosis is actually quite common. About 20% of women have some degree of endometriosis. And you can see here, they have a surgical instrument going in with a blade, and so that'll be taking off some of this endometrial tissue. And you can see it's called the rectovaginal endometriotic tissue. And so this is basically between the rectum, which is back here, and then, of course, the base of the uterus down here would then become the vagina. So this is in the space between the uterus and the rectum. And then we can see here this little bit of endometriotic tissue. All right, so again, here they're cutting out some of the endometriotic tissue that may be swelling and causing pain. Here they're using suction, so like we had one of those chocolate cysts, they can suction it out. Here they're suctioning out some of the endometriotic tissue. So it says a huge endometriotic cyst. So this would be fluid contained within here. So in the video, they talked about various different kinds of treatments. One of the primary ones is to use the pill. So if you provide the individual with lower levels of sex hormones, estrogen, progesterone, that will actually negatively feed back and will decrease the amount of estrogen, progesterone made by the individual. So you tend to have a lower stimulation of that endometriotic tissue that helps reduce the amount of growth of it and reduces the pain and irritation associated with it. Okay? And then, of course, surgery, and then sometimes you can have a combination of hormones and pain meds and surgical treatments. All right, I thought I'd mention a little bit about uterine fibroids or leiomyomas. One of the reasons I would do this is because we actually see some in our cadavers, and so students would always ask, and so I had to put this in here. There's various areas where you can have fibroids occurring, and fibroids are super common, especially as we get older. So these are non-cancerous growths. They're asymptomatic. No one's really sure why they grow, but they do grow either on the inside, which would be an intramural. Sometimes they grow within, submucosal. Sometimes they grow within the muscle, which would be intramural. And sometimes they can grow on the outside surface, which would be subserosal. So below the serous membrane, below the mucosal membrane, or within the muscle membrane. So intramural, submucosal, or subserosal. And basically, it's just an area, really super duper thick area of collagen fibers. They tend to mostly be asymptomatic, so you probably have fibroids and don't know. The older you are, the more likely you are to have fibroids. And usually in someone who's over 45, if she has fibroids, it's not going to cause any problems anyway, because her uterus is no longer producing an endometrium. But if they get really, really big, then they can cause problems. If you have someone who is still menstruating, they can actually irritate the endometrium and cause heavier menstruation. They can also cause some pelvic pressure because they can be heavy and weigh on other organs. You can have some fibroids the size of softballs, so they can be really big. And they can cause problems with emptying the bladder and constipation and things like that if they're really big and obstructive. And so usually what you go in is you just surgically remove them. All right, so I have here uterine fibroids, no cause unknown, risk factors, things that can potentially cause them might be things like high levels of hormones, if you're on hormone therapy for a long period of time, maybe you have reproductive or psychogenetic problems. Treatments, again, are going to be hormone treatments, so they know that if hormones are a risk factor, if you take birth control pills, but usually they can surgically go in and remove them. They can also use lasers and ultrasounds to basically rupture them, or they can basically sever the vasculature to them so they stop growing. So different techniques. You can see here, this is an MRI, and what they're using are ultrasound waves to kind of blast the fibroid. All right, almost done. So now we're in the birth canal, which is the vagina. The vagina is about 3.5 to 4 inches, depending on the individual. It can be longer or shorter. It also depends on whether or not you had previous vaginal deliveries. Tends to stretch super big because you have to pass a baby through there. So when we look at the vagina, it's going to have a lot of folds in it to help allow it to stretch. So we have the same kind of rugae that we would see in the bladder and we would see in the stomach to allow for that stretching. We're going to have a stratified squamous epithelium because we want to make sure that during copulation, we don't damage that inside lining and allow a path for infection. And also for the baby, you want to make sure that we don't rupture the vagina open when the baby comes through. So we have a stratified squamous epithelium with lots of rugae to help us stretch and expand the vagina. All right, and then this is a view of the vagina here. So the vagina is actually an internal structure, not an external structure. I know a lot of us think of the vagina as our external genitalia, but we would call that the vulva or pudendal region. The vagina is actually internal. So the vagina is this passageway from the outside of the body to the cervix as being the entry point into the uterus. All right, the hymen is really part of that sort of irregular folding that we see inside the vagina. And sometimes you can create areas that are a little bit tighter than others. So if a woman is having intercourse for the first time, sometimes there's some pain and bleeding that might be associated as some of that hymen tissue tears a little bit. Okay, so that's kind of the irregular folding you kind of will see right here. All right, so this is looking at the external genitalia. This hole right here, obviously that's the entryway into the vagina. Just in front of it, this is the entryway into the urethra. And of course, behind it, that of course is the digestive system. So we have urinary, reproductive, and then digestive. The space here that kind of surrounds and houses the entryway to the vagina and the exit through the urethra, this is called the vestibule. So it's sort of this inside between the two labia minora. All right, so mesenteries, we're going to look at the broad ligament. Remember, we talk about the huge broad ligament as being this really beautiful sheet that kind of comes over and drapes and supports the whole reproductive tract. Technically, it's just the parietal peritoneum becoming visceral peritoneum, but the mesentery that is that parietal peritoneum and coming up again, it's going to be a double sheet of membrane, so just like any other mesentery, but we're going to call it a ligament because we're going to have a lot of connective tissue in it. So it's this huge sheet that kind of shrouds and drapes over the reproductive tract. It's going to support the fallopian tubes and the ovaries and, most importantly, the uterus. All right, so here you can kind of see, this is really beautiful. See this stretching here? That's the broad ligament. You kind of see the sheet here kind of draping over. Within the broad ligament, we have specializations. So imagine if you were walking around with a sheet over your head. If you stick your arms out where that sheet wraps over your arms, that's what you're going to call the mesosalpinx. Salpinx means trumpet, and that referred to it's an old name for fallopian tube, salpinx. And then you can imagine if you were holding pillows, right, in each of your hands, those pillows would be the ovaries. And if the sheet wrapped over the pillows, that would be the mesoovarium. So really we're looking at the fallopian tube here. So this portion of the broad ligament that kind of connects to the fallopian tube, that's the mesosalpinx. And then the portion that wraps around the ovary here, that's going to be the mesoovarium. So we're looking at here, this is a drawing. This, of course, would be anterior. This is posterior, and this is the broad ligament. So remember, it's a double serous membrane. So this is one side of that serous membrane coming up. It's going to flip over the fallopian tube. It's going to cover it, and it's going to come back down again. Remember that when we have mesenteries, we're going to also route blood vessels through those mesenteries along with some connective tissue. And that's what we see here, but there's a lot of connective tissue, so that's why we call it a ligament. So this portion that wraps over the arms here of the fallopian tube or uterine tube, this is going to be the mesosalpinx, and that's going to wrap out and around the ovary, and that's going to be the mesoovarium. All right, we already talked about the suspensory ligaments. So the suspensory ligaments, oh gosh, I just turned off my light. The suspensory ligament is going to go from the lateral posterior body wall, so the dorsal body wall, out to the ovaries. You kind of see it right there. So this would be the suspensory ligament on this side. The ovarian ligament, I can't quite see, but it's going to be in this connective tissue here. That'd be the ovarian ligament. I can see the fallopian tube. And last but not least, I can see in this view the round ligament that's kind of coming up and going this way. That's the same as the gubernaculum in males that pulls the testes down the dorsal body wall and then goes into the inguinal canal. It does the same thing for the females. It goes into the inguinal canal, and in females we call it the round ligament. Okay, so this is looking at the fallopian tube right here. There's the ovarian ligament, and then here we see the ovary, and then the round ligament is going to move forward anteriorly toward that inguinal canal. All right, so this is just a beautiful drawing. I love this one. So we're looking down in the pelvis. So here's the rectum posteriorly. I can see the uterus is tipped forward. I have the bladder sitting in front. So this right here coming off and going forward and then into the inguinal canals here. That's the round ligament. I have my fallopian tube kind of angled laterally and then swings around posteriorly, kind of hug these little pillows of ovaries, right, on either side. So connecting the ovary to the uterus, there's my ovarian ligament on either side. And then I have the ovarian artery and vein. So these would be the gonadal vessels that we call the suspensory ligament. Okay, sorry. All right, and then last but not least is the external genitalia. We often refer to this as the pudendal area or pudendum. In the females collectively, we'll call it the vulva also. But portions of the vulva or the pudendal area, we have the mons pubis, which is this kind of fatty pad that covers the pubic symphysis. So during intercourse, when people are having sex and you're hitting that pubic symphysis, it's a little bit of a cushioning there. We have the labia majora and labia minora. Remember, the labia majora are going to be outer folds. They're going to have pubic hair on them and sebaceous and sudoriferous glands. So they're going to secrete sebum or oil, and they're also going to create an odoriferous secretion, so similar to your armpits. So they're going to have odor to them. And these are what are homologous or the same in the male as the scrotum. So the scrotal tissue and the labia majora are homologous, derived from the same embryonic tissue. The labia minora are the inner folds. They're going to not have any pubic hair on them, and they're going to be devoid of most of the sudoriferous glands. This would be homologous with the skin over the shaft of the penis. So if you look at a penis, you're going to see the skin over the shaft, and you'll notice it has very little hair. Definitely doesn't have any terminal or pubic hair. And then we look at the vestibule. Again, the vestibule is just really the space between the labia minora. It's that common space. It's kind of like the pharynx we see in the oral cavity. It's going to be a common place for the exit of urine as well as reproductive substances. So that's called the vestibule. All right, so in this view here, these are the labia minora, and so this space is called the vestibule. And again, I'm going to have my urethra, my vagina, and then outside the vestibule, of course, is the anus. All right, and then I mentioned in lab that females and males actually have the same erectile tissue, which I personally was shocked when I found out. I was like, what? So males obviously is much larger and it's more external, so we see it better. But females also have the corpora cavernosa, and they will form these lateral extensions, posterior lateral extensions that anchor the erectile tissue to the pelvis, just like in males. So we have the corpora cavernosa, and these are going to be the crusts, right? The legs that would be extending out and attaching to the pelvis. And then we have the bulb of the female, so we call this the bulb of the vestibule rather than the bulb of the penis. The bulb of the vestibule, it's going to have two sides rather than a single, and that's because it has to go on either side of where the urethra is going to be coming out. So in females, this is the bulb of the vestibule on either side, so that's going to be corpus spongiosum. And then as we go anteriorly, we're going to see that combo, which is essentially where we're going to have the glans clitoris and the clitoral body. So the glans clitoris is going to be homologous to the glans penis, and then the clitoral body will be homologous to the shaft of the penis. So that's going to be primarily cavernosal tissue. All right, so I have here the glans clitoris is the exposed erectile tissue, just like the glans penis is in males. It's going to be covered with foreskin, which we refer to as the prepuce, and it's going to sit in the anterior labial fold. Okay? The bulb of the vestibule is going to be homologous to the bulb of the penis, and it's going to be just on either side of the vaginal canal and the urethra. All right, and then remember the clitoris is going to be in males. We have the Oh gosh, sorry guys. The glans penis in males, and we have the glans clitoris in females. Remember, the cavernosa creates the shaft, and we're going to see that same structuring here. So this is the shaft, or the clitoral body, and then we have the glans clitoris, which again is going to be very innervated, very sensitive. All right, so the clitoral crus, so these are the legs out here, those are going to be homologous to the crus of the penis. And then also we have a glandular tissue associated that has homology. And remember, in females, we're going to have glands called paraurethral glands or Skene's glands. They're going to sit on either side of the urethra. And just remember, if you're right around that urethra, in males, remember the urethra travels right through the prostate. So this is going to be homologous to the prostate. When women have ejaculant, they're going to be releasing a fair amount of fluid from these periurethral glands. Every woman is different. Some women have more secretion than others. So there's a lot of variability in females. But this is a clinician. You can see the gloved fingers here kind of pulling, I should say, the labia off to one side. I can see the clitoris here, so that'd be the glans clitoris. This is the prepuce, or the foreskin that kind of covers over the glands. And then this is looking at the vestibule. So I have right here, that's the urethra. There's the vagina. And just off to the side of the urethra here, we see the opening to the Skene's gland, or the paraurethral gland. There'll be one on each side, so we just don't quite see the other one. All right, so again, this is homologous to the prostate. And then we have what's called the greater vestibular gland, and these are going to be homologous to the bulbourethral glands. So remember, in the male, you have the bulbourethral glands that are sitting right at the bulb of the penis, and that's why they're called bulbourethral. They're sitting right at the bulb of the penis. So in females, we have the bulb of the vestibule that these are going to be associated with. So the greater vestibular glands, also called Bartholin's glands, are going to have a lubricant. And this tends to be a little bit more viscous, and so oftentimes can actually get clogged or block the aperture to the gland, and you can get what's called a Bartholin cyst. So very similar to like a pimple that you might have. All right, so I just thought I'd finish this up with a quick little video on fertilization, because this is kind of a cool video, but essentially we're done. So you can watch it if you want or not.
Fertilization is the epic story of a single sperm facing incredible odds to unite with an egg and form a new human life. It is the story of all of us. During sexual intercourse, about 300 million sperm enter the vagina. Soon afterward, millions of them will either flow out of the vagina or die in its acidic environment. However, many survive because of the protective elements provided in the fluid surrounding them. Next, the sperm must pass through the cervix, an opening into the uterus. Usually, it remains tightly closed, but here the cervix is open for a few days while the woman ovulates. The sperm swim through the cervical mucus, which is thinned to a more watery consistency for easier passage. Once inside the cervix, the sperm continues swimming toward the uterus, though millions will die trying to make it through the mucus. Some sperm remain behind, caught in the folds of the cervix, but they may later continue the journey as a backup to the first group. Inside the uterus, muscular uterine contractions assist the sperm on their journey toward the egg. However, resident cells from the woman's immune system, mistaking the sperm for foreign invaders, destroy thousands more. Next, half the sperm head for the empty fallopian tube, while the other half swim toward the tube containing the unfertilized egg. Now, only a few thousand remain. Inside the fallopian tube, tiny cilia push the egg toward the uterus. To continue, the sperm must surge against this motion to reach the egg. Some sperm get trapped in the cilia and die. During this part of the journey, chemicals in the reproductive tract cause the membranes covering the heads of the sperm to change. As a result, the sperm become hyperactive, swimming harder and faster toward their destination. At long last, the sperm reach the egg. Only a few dozen of the original 300 million sperm remain. The egg is covered with a layer of cells called the corona radiata. The sperm must push through this layer to reach the outer layer of the egg, the zona pellucida. When sperm reach the zona pellucida, they attach to specialized sperm receptors on the surface, which triggers their acrosomes to release digestive enzymes, enabling the sperm to burrow into the layer. Inside the zona pellucida is a narrow, fluid-filled space just outside the egg cell membrane. The first sperm to make contact will fertilize the egg. After a perilous journey and against incredible odds, a single sperm attaches to the egg cell membrane. Within a few minutes, their outer membranes fuse and the egg pulls the sperm inside. This event causes changes in the egg membrane that prevent other sperm from attaching to it. Next, the egg releases chemicals that push other sperm away from the egg and create an impenetrable fertilization membrane. As the reaction spreads outward, the zona pellucida hardens, trapping any sperm unlucky enough to be caught inside. Outside the egg, sperm are no longer able to attach to the zona pellucida. Meanwhile, inside the egg, the tightly packed male genetic material spreads out. A new membrane forms around the genetic material, creating the male pronucleus. Inside, the genetic material reforms into 23 chromosomes. The female genetic material, awakened by the fusion of the sperm with the egg, finishes dividing, resulting in the female pronucleus, which also contains 23 chromosomes. As the male and female pronuclei form, spiderweb-like threads, called microtubules, pull them toward each other. The two sets of chromosomes join together, completing the process of fertilization. At this moment, a unique genetic code arises, instantly determining gender, hair color, eye color, and hundreds of other characteristics. This new single cell, the zygote, is the beginning of a new human being. And now the cilia in the fallopian tube gently sweep the zygote toward the uterus, where he or she will implant in the rich uterine lining, growing and maturing for the next 9 months until ready for birth.